Hi, friends. I'm here with Dr. Andrew Campbell, a good friend of mine. I think I've known of his work for many times. He's written some great papers on mold and mycotoxins and water damage buildings. And You definitely want to read some of his research on that if you haven't already. And First time I think I met you, Andrew, was at Aristo's birthday, Aristo Vigiani's birthday. And I heard about you for a very long time. And I know you're editor-in-chief, Alternative Therapies and Health and Medicine, and um, Ari, Dr. Vigiani, it always spoke so highly of you. And you got to meet Andrew Campbell. You got to meet Andrew Campbell. You got to meet Andrew Campbell. So we finally got to meet, and you're such a nice guy. We talked a lot of great things and had a great conversation, and we've been friends since. And I definitely wanted to have people in my community get a chance to hear from you and talk about mold. You've had a lot of experience with mold toxicity as well as, just being a good physician. Before we get into mold, just a quick background about how you got into the specialty and got into medicine, and then we can kind of take it from there. So some of our people don't know your history.
Okay. So, I graduated from prep school, and I was educated in Switzerland, prep school, and I graduated a few days before my 14th birthday. And then I came to the States. I did college in 3 years, and then I did medicine. And then I trained initially in surgery and then cardiothoracic and a surgery, but then decided that wasn't the life for me and went into immunology and then toxicology. And so the first thing that led me to molds was silicone breast implants. I saw a lot of women. I was based in Houston until a few years ago. So I was young, I established my practice, and I saw a lot of women who had the same symptoms. I started keeping track of those women, no computers back then, and noticed they had one commonality, which was silicone breast implants. Young, old, whatever size, they all had basically a group of symptoms. And so then I found a lab at a conference that does testing on the immune system. And that was Immunosciences Laboratories and Dr. Vojdani. And this is 89. So before either one of us had a single gray hair. And so we had a long talk, and I started using his lab on these women with silicone, and we noticed a pattern. So we started publishing studies on that. And I think we published maybe 25, 30 studies together and with other doctors on the effects of silicone breast implants. And then I was asked to come to Washington, D.C. and present the data to NIH at a big, huge roundtable. And I did. And then 6 months later, they banned silicone implants.
Wow, that's fantastic. So, I had a similar story. I met our Dr. Vijay, Dr. Aristo, who we call him Ari, we're friends with him, and he had at that time had silicone antibodies for breast implants. And I remember I called him. I was like, "Oh, I have a patient who's sick. I think they may have silicone issues. Of course, test them." And then we tested him, and she had neurological antibodies. And he's like, "They're both high at the same time. What do you think is causing that?" And I was like, in my 20s, I'm like, "I don't know. I'm out of school. Tell me what to do. Tell me what this means." And I got that first impression, and then it became really relevant. That it was a big thing. So the question was like, some people have these reactions, and then turns on the triggering point of chemical induced autoimmunity then developing, and then some don't. Now, where do you think we are with breast implants now? Because now they have different types of implants that don't use silicone, and there's hundreds of different chemicals in them. What is your current thought on implants and illness, and how do you check for it? What would you do?
They still have problems, and Dr. Schoenfeld in Israel has called this ASIA, ASIA.
Okay.
And basically what we learned back in those early 1990s was that even women who who had their implants removed,
Right.
improved maybe 10%, some of them 20%, but they weren't completely well.
Yeah.
So I found a PhD in Canada, Montreal, Canada. And since I was educated in French, English, I spoke with an accent way back then. And I found this PhD who did studies on failed implants, chin implants, TMJ implants, knee implants, hip implants, and breast implants. And he would examine them, et cetera, and see what went wrong and give advice to how to make them better. Well, I called him and he invited him to Houston, and we both had long conversations. And I said, all implants come in pairs in a box with two. I said, what happens when you get one implant ruptured in a woman and the other is still, complete, unruptured? He says two things. All implants leak. In other words, if you put them on a piece of paper, any kind of paper, and leave them there for 30 minutes and then remove them, there's going to be an oily stain on that paper. So the second part is when they've been in the body for a while, the intact implant actually shows inside this implant floating things, discolorations, green, orange, black, and those are molds.
Oh, geez.
So I said, well, how do molds get inside? He says, through the manufacturing process. And he had advised all the different manufacturers that their implants eventually have molds and they should modify how they make implants. So I gave these women who had their implants removed an antifungal, itraconazole, Sporanox, and they all got better. So then I started seeing patients who says, well, you helped my aunt, my grandmother, my mother, my sister, my neighbor. Can you help me because we found mold in our home and we're all sick?
Right.
So that's when I called Dr. Vojdani again, together with him, and says, let's do this and this. What do you think? And so we did, and we started collaborating together again on the issue of molds and mycotoxins. Mm-hmm. So just like it happened with the implants, you kill off molds. Molds are everywhere. So, they're in this office. They could be anywhere. But until you get them wet, and they don't do anything. So if you get them wet and they're wet for 24 hours or more, they start to sporulate, release spores. Hair is 100 microns thick. Mold spores are 2 to 3. So they go into the deepest part of the nasal sinuses and of the lungs. And since they get into the lungs, they get to the alveoli, they can pass right on through the blood and circulate and go wherever they want. Now, mold spores are 0.1 microns.
Wow.
So they're the size of a virus.
Okay. Like right. So they get through anything. So let me pick your brain for a couple of things that we all face as clinicians. One is patient comes in, they're extremely sick, they have an autoimmune disease. And so one of the clinical scenarios is, do I get rid of my breast implants? Would you say it's always an yes?
If they have breast implants, you have to demonstrate clinically that that's what's making them sick.
Right.
So the easiest thing to do is to get a autoimmune panel.
Right. So let's say they have autoimmune markers there. Now, I know immunosciences doesn't do silicone antibodies, and I remember Dr. Vojdani saying, I just don't want to be in court all day, because he was getting dragged in court all day because everyone was getting sick with these implants and he had to go and be an extra witness, and there was other issues, and it became a target, and it was like, I don't want to do this anymore. So he just took the marker off because it was completely disruptive to his lab, to everything. And so much litigation was happening from it that he just didn't want that world. But now we're at a point where we don't have markers to check silicone antibodies, and even some of these chemicals are not even, there's not even commercial testing for them that are in breast implants. So, the only thing we do have is, for example, the autoantibody markers that they have autoimmune disease. So is there any way to, unrelated to mold testing, but is there any way to test if the breast implants are making them sick, other than having the expression of autoimmune disease, that you think is effective?
So the tests that can be done now, besides the fact that they do cause autoimmune disorders.
Yep.
So an autoimmune panel. The other test is mold spores carry with them mycotoxins.
Right.
Molds are the gun. Mycotoxins are the bullet
Okay.
that make you sick. So you use the mycotoxin test to see if these are actually causing the test, the disease or the symptoms. Because if the antibody test to mycotoxins is high, well, that is an illness in itself. So the next step the clinician has to find out is there mold in your home or workplace?
Right.
They say, no, we had it checked, it's clean, et cetera, then it's obviously the implant.
Okay. So let's say I want to put you in clinical scenarios, because we're in clinical scenarios and we sometimes need, someone to talk to about it, figure out what to do. So if we have a clinical scenario where the patient has confirmed autoimmunity, maybe they have antibodies, maybe they have TPO antibodies, maybe they have mild antibodies, but there's some kind of autoimmune disease that's there. That's been confirmed. They've been diagnosed. Now the question is, should they get the breast implants removed? The answer is always yes.
Yes.
Always
if it's making them sick. Because by now I've seen thousands of people with women with breast implants. I saw many from Hollywood, of course, and from all over the planet, actually.
Right.
I've also seen those who have injections of silicone.
Right. And I think that thing to understand is, and the point that you made was, they get their implants removed. Doesn't mean they become cured, because the autoimmune disease is turned on. Now, some may have symptom relief, some may not. And then what would you say is the percentage of people that have symptom release? And what would you say is the percentage of people you've seen in your experience that go into a dramatic remission?
So here's the key to it. We know about pathogens. There's microbiology consists of 4 pathogens: bacteria, viruses, pathogenic fungi, and parasites. And all those are living things. They have cell walls, cell membranes, etc. And the immune system reacts to them in a well-known and well-defined pattern. I had chickenpox when I was a small child. I now have chickenpox antibodies circulating in my blood. Am I sick? No. They're just there because I had that infection. Now we're talking about silicone and other toxins. So we're talking about toxins like mercury, silicone, mycotoxins. Those are not alive. They don't have cell walls. They're molecules. So the body's immune system reacts differently to a molecule. And the first rule in toxicology is get the patient away from the toxin, or the toxin away from the patient. In this case, explantation. Yeah. Then there's nothing stimulating the immune system anymore. So then you support the immune system with supplements.
Right. But the point is, like, as practitioners, we have to let our patients know, tell me if you agree with this. You're going to take these implants out. It doesn't mean you're going to be cured. You may have some symptom relief, but the point is you're no longer getting this constant chemical barrage to your immune system. That's one of the things, an autoimmune disease, we're always trying to reduce chemical load, is one of the variables that can be promoting a disease. Is that a good way to approach it, or to explain to the patient?
What I have seen in the more or less 14,000, a little bit over 14,000 patients, is that once you remove whatever is causing their problem, in this case, silicone implants, but let's say mold in the home or something like that, and you treat them and you give them itraconazole. It works much better than some of the other antifungals because it's got the best profile and it crosses the blood-brain barrier, which is very important. So what happens in this case, and you give them the Sporanox and you give them support with supplements, it takes them about 2 months before they start feeling any better. And then you continue the treatment. Usually within 6 to 8 months, they come into you. How are you doing? It's their regular visit. And they say, I really feel pretty good.
Good. Okay.
That's when you know you've cured them.
Okay. Now, do you think, so you don't have to have leakage, right? Because these chemicals are getting through, like you said, all together. Do you think modern production of breast implants are still having issues with mold? Or is there a time period where some of the older manufacturing practices were leading to mold?
No, we don't know about that part because the manufacturers learned their lesson and are very careful in anything to do with that. And they got really hit bad by lawsuits, lost a lot of the money, and then they were shut down by the FDA. So you can imagine what they went through, and now they're very cautious and they're very closed on anything to do with manufacturing or anything like that. You can't find any information until a federal judge, not a district court judge, a federal judge gets them to open it up.
So we don't know.
So, I can only tell you that when they do, I had recently a young woman, 23 years old, lovely young lady. She came to me. She was sick. She had the implants put in 6 months previously because she was going to get a job at a TV station as the weather spokesperson. And she wanted to look great. Fine, that's great. That's wonderful. But she got sick in 6 months. She was very ill. I did a autoimmune panel. She lit up ANA, and she lit up ANA and RA factors were both positive. She says she doesn't care. She's getting her implants out because she started feeling bad about a month after they put in the implants. She had the implants removed. She started feeling better. I still treated her. 4 months later, she was perfectly fine.
Okay. Now, the thing is that, we gotta be very, like, as practitioners, and I'm sure you've faced this, is giving expectations, right? So it's like, you gotta be careful. So how do you handle this discussion? Do you say some of your patients have some outcomes, that have some cases where this scenario happened, or just wait and let's see what happens? But how do you have that discussion with them? Because for some women, when they get the breast, some women that are sick, their breast implants, and have become a sense of their self and their how their beauty and how they look and they appear, and for them it's a big move to replace them, and especially if they replace them and they're still sick and they see no change, then they can start getting angry at the practitioner, and that's a very sensitive discussion to have to maintain a healthy relationship with the patient that's dealing with this. What kind of things have you noticed come up with those types of relationship issues, practitioner patient issues?
Here's what I do.
Okay.
I tell them this is the medical evidence.
Okay.
Okay. So this is what medicine and science has said about this. If you have control over your health, you are the one responsible for your health. So I'm just informing you of the possibilities. If you do this, then this. If you do that, then that, etc. You have to go home, think it over, discuss it with your other half or whoever you trust, and then get back to me and tell me what you choose. And I have a few articles ready to hand them so they can take it home. They won't understand it, but they will understand the abstract because that's pretty plain. And and I say it's up to you what you want to do. But in my opinion, and this is just an opinion, I don't have the facts yet because I haven't done any testing in you yet. If I do testing, I'm going to test your autoimmune system and I'm going to test you for mycotoxins. But go home, think about this, and then get back with me.
Right. Perfect. So I want to talk to you about testing, because testing.
Document this.
Yeah. Right. Of course. Let's talk about mold testing. This is an area where, there's different opinions, especially with mycotoxins. So I think when we look at mold, we can measure through antibody, or we can measure the mycotoxin quantitative measurement. And, they're both, one's telling you immune response, one's telling you the presence of some toxin that's in the body. Now, some people have said that mycotoxins and urinary mycotoxins may not be as reliable because you may be ingesting, mycotoxins with foods and things you eat. It may not necessarily be from your home and from exposure, from some toxic insult. So those are we have to look at this with caution. And then we have antibody testing where, you have exposure to mold, which raises antibodies. And then you have people that develop full-blown mold allergy where they have IgE responses. Like that's the general spectrum of mold testing as I understand it. What kind of input would you give us about mold testing and what you prefer to do? And what do you see the benefits of one type of testing versus another?
So one thing is that you and I both know that there's medical science evidence in what we read.
Right.
It's great to have an opinion. Everyone has that right. We saw that in the last presidential elections, but we as clinicians seeing patients have to base ourselves on what is medical science. So the science says that there is no evidence that urine testing, as currently the method they use, is valid for other than the parts per billion that occur in urine. For example, Dr. Fry last year, 2021, published a study, Fry and his group, it showed that 91% of cow's milk, the kind you pick up at the supermarket, has anywhere from 1 to 4 mycotoxins. And that 32% has 2 or more mycotoxins. So does that mean that we should stop having milk? We should stop having ice cream? No.
Yeah.
It's below what is called TDI, tolerable daily intake. That's set in the United States by the FDA, in Europe by the European Food Safety Authority, and various other entities. So when it's that small, parts per billion, you just pee it out because urine is an excretion. It's getting rid of stuff your body doesn't want. I asked a mathematician that I'm a visual and I cannot understand what is a part per billion. He says, take 100 football fields, cover them with golf balls, remove 1 golf ball, that's 1 part per billion.
Wow, that's a good analogy.
That's a great way to visualize this, especially for a guy like me. So, when you get 2 to 3 or 4, 8 parts per billion, we do that all the time. I sometimes go like this with my glasses. Well, there's all kinds of stuff here, and so on and so forth. So we're exposed to stuff all the time, but our immune system works great. And we both learned that from Dr. Vajdani. Yeah. It gets rid of it. And how does it excrete it? Mainly through urine throughout the day. There's a recent study that came out in 2020 that shows if you really want to know how much is in your food, you need to test your urine for mycotoxins 4 to 5 times a day. Okay. Because it differs during different parts of the day. Okay. So at breakfast, you might only have a yogurt, and that might have a little bit, but at lunch, you're going to have asparagus, you're going to have some chicken, and that has more chance of having something. And then in the evening, you're watching TV and you're eating peanuts. So you have to do it throughout the day. The other thing is that the method is not reproducible. In other words, split samples show huge differences. Whereas the antibody test is very, very specific. It's like a key and a keyhole. The key to the front door of my house will not work to open the door of your house, because it's very specific for that particular mycotoxin. And as you mentioned, it's a quantitative test. It tells you what is the body burden, how much. The other part is mycotoxin antibodies are being used by universities. In particular, my microlab just finished a study with Washington University School of Medicine in St. Louis. Another study is going on with Tufts School of Medicine up in Boston, where you studied, got your PhD at Harvard. And then second at Rutgers University. And last but not least, Helsinki, Finland. And they've been in the news lately, but the reason they're doing the test is because Finland has the highest rate of dementia in the world. Okay. And studies have shown that in brains of people who have died with Alzheimer's, 28%, and this is a US study, not a Finland study, 28% died and they had mold and mycotoxins in their brain. Two more studies have come out, one looking at Parkinson's, three studies, one at Parkinson's, one at ALS, amyotrophic lateral sclerosis, the other at Alzheimer. In the Alzheimer one, they only looked at fungi. They found fungi in all parts of the brain, including the cerebrospinal fluid. In a study on mycotoxins from a completely different university medical center, found that in Parkinson's, all parts of the brain had mold and in the cerebral spinal fluid. In amyotrophic lateral sclerosis, ALS, it turns out that, and this is from several publications, 5 to 10% of ALS is caused because of genetic issues. The rest is due to mycotoxin exposure from an indoor environment, which is huge.
So to go, so that's amazing information. But to go back to testing, so we can all assume urinary mycotoxins are highly influenced by dietary intake, and there's a difference between urinary mycotoxin quantitative measurements and mycotoxin antibodies. And you, with your experience, have found and prefer the mycotoxin antibody because it's a specific immune response. Is that correct?
If you check with the urine labs, none of them have ever been asked by a university to do a study.
Right.
And they've been around for a lot longer.
Yeah, I agree with you. I mean, I have the same thing. We see urinary mycotoxins. We're always like, oh, is this really toxic mold exposure, or is it just from exposure to foods that build up over time? And is this reliable? And I'm with you. I definitely think antibodies are more reliable. Now, when you look at antibodies, you can measure antibodies to mold species, and you can measure antibodies to mycotoxins. Do you have a preference for one versus the other?
Well, if you're measuring molds, antibodies, and you're measuring mold as a pathogen. So you could have gone to a summer camp when you were a teenager, been infected there, and now and then got over that, and you still have antibodies, just like if you would have had, I don't know, hepatitis or something. Right. Whereas if you go to a toxin, once the toxin is out of the body, you repeat the antibody test and it's all normal.
Okay, so the mold mycotoxin antibody itself is a greater reflection of active exposure, and whereas the mold species you feel is a better expression of past exposure to mold. It doesn't matter for you if it's IgG, IgE. Well, I mean, let me take that back. Does it matter for you if it's IgG or IgA, or none of those things really make a difference? It's just if it's a mold species, then it's just past exposure, but mycotoxins reflecting active levels that are triggering the immune response. Is that correct?
Good point.
Yeah.
One mold makes several mycotoxins, and one mycotoxin can come from several molds. The second point is IgG means there's a current toxic reaction going on in the body. Your immune system is fighting this. Mm-hmm. And here's how much it's fighting this mycotoxin, that one. There's 12 mycotoxins. Right. There's over 400,000 species of molds, but only 25 affect humans. So in the testing, you're looking at 12. Now the IgG means that, but the IgE antibody, what that does, it stimulates mast cells to release pro-inflammatory cytokines. And these pro-inflammatory cytokines like IL-6, et cetera, and others, will start causing inflammation. And because these cytokines affect mast cells are near the regions of the brain. There's outside the brain, but they're near the brain, near the skin, near the opening to organs. You get inflammation. That's why they get hives and things of that nature.
So Dr. Campbell, yeah. So Dr. Campbell, so tell us, so you work with Mycolab, right? You're in the, you're medical advisor there, and they do mold mycotoxin antibody testing.
They do 12 different antibodies with IgG and antibodies. The IgE antibodies mainly lights up if you have mast cell activation or mast cell activation syndrome. I just submitted a paper Monday for publication with Dr. Weinstock, who is professor at Washington University on mast cell activation syndrome using the test from my microlab, the IgE.
Okay. That's very interesting. So when people go on like a histamine free diet, are they really going on a mycotoxin free diet more so, do you think? Is it really
they're going on a, well, yes, because when you stimulate, when you have an IgE antibody to mycotoxins and you stimulate your mast cells release heparin
right?
and all the and histamine and all these things. So if you want to try attacking that by that aspect, it will help for a while. But the key thing, and I think we've both learned this from Dr. Versdani, is identify the cause, remove the cause, repair the damage.
Right.
So once you remove the cause, treat the cause, repair the damage, then you don't have to worry about a histamine diet anymore.
Right. Yeah, I see. I definitely see the point there. So let me ask you a couple questions. In the healthcare environment, we definitely have people that specialize in mold. And when you think about, when I mean by that, there's people that specialize in mold like yourself that are experts. They publish papers and share the research. And then there's people that I would say maybe not are experts in mold, but they're mold biased practitioners. What I mean by that is everything is mold. So everything they see is like through mold eyes. Like they think maybe they had it, and usually what you see is they had a history with toxic mold impacting their health. And then from now on, whenever they see someone's chronically sick, they think it's got to be mold. Now, if that's the case, and they measure mycotoxins, and the person's eating foods with lots of mycotoxins, and the patient they have is going to the health food store and taking things out of bins and things that have a high mycotoxin content, if they do a urinary mycotoxin test, they're just going to see they're high, which may actually not even be necessarily the trigger of the immune response, because they're not actually measuring antibodies, which is the trigger of their immune response. It's just what is showing up, clearing out through our urine system. We all have some degrees of mycotoxins exposure with food, just like we all have some degree of chemical exposures from all types of things in the environment. So that really puts, makes it easy to identify a lot of people and come up with the conclusion, oh my goodness, this is mold, and that's probably making you sick. And then there's also the possibility of antibodies that relate to expressions, maybe not even current, but years ago. How long do you think the IgG mold species antibodies, not mycotoxin, mold species antibodies, how long do you think they stay high for?
Once you start treatment.
Well, let's say without treatment, just say someone walks in.
Well, if they'll stay high as long as they're in the body. So unless
but not mycotoxins, but let's say just if we're making Stachybotrys or some kind of mold species itself.
Oh, mold species. Okay, so mold spores of, say, Stachybotrys, carry on the mycotoxins. So let's say they colonize in your nasal passages, in your sinuses, or in your lungs, or someplace.
Yeah.
Then what'll happen is that'll cause an immune reaction. And that immune reaction will have antibodies. So as long as they're still alive, you're going to have an antibody. You're going to remain positive to the antibodies.
But how long do you think for? 1 year, 2 years, 5 years, your entire life?
Well, Dr. Ponikaus published a study, head of chairman of the Department of Ear, Nose, and Throat Surgery at Mayo. He took 210 patients to the OR. All of them had chronic sinusitis. He cleaned their sinuses out, sent the material to the lab, and asked for microbiology analysis. 96% was mold. And that's a high percent in medicine. He actually petitioned that chronic sinusitis be changed to chronic fungal sinusitis. The point is that he gave them two things. One is amphotericin B nasal spray and itraconazole. And they all got better within 6 months. Now, in another study, they decided to see okay, this patient has been followed for X number of years with chronic sinusitis, etc. Now we tested them, and yes, it is mold in their sinuses. Well, they started having sinusitis 12 years ago, and they're still having sinusitis. They tested for mycotoxins. They were positive for mycotoxins 12 years later. So we know it's 12 years.
Okay.
There are no studies that show 13 or more. There's 12 years is the oldest.
Are there any studies that you've done or have been published where we can look at mycotoxin antibodies, where we can actually clearly see there's treatment, they go down, and it's not past exposure? Has that been done yet?
Oh, yeah. Oh, many. Stacks and stacks.
Okay. Mycotoxin antibody reduction post-treatment.
Yeah, I mean, I have a lot of patients, and we're planning to publish this before and after. We know that mycotoxin IgG antibodies bind to human tissue. Let me simplify. Right. Bind to human tissue and cause an autoimmune reaction. Right. So we have patients with full-blown psoriasis. We test them for mycotoxin antibodies, they're positive. 6 months later, 6 months of treatment, they're fine. They don't have any psoriasis. Right. And I have photographs if you want me to show them to you, if you want to.
No, yeah.
And then we retest them, and they were highly positive before we started treatment, and now they're normal. I mean, there's nothing.
Okay, so you find it reliable to measure mycotoxin antibodies, the way to determine if there's an acute response to mold and preference of urine or actual mold species, and then you find it reliable if the treatment's effective to see those mycotoxin antibodies lower or become negative.
No, they're either very, very low, and this depends. Like the one lady, and she's the mother of a doctor you and I both know and have seen in lectures. He sent this to me. He says, can you help my mom? And so, yes, of course I did, and all that. Well, hers didn't return completely to normal because she was a smoker.
I see.
But I mean, she had low. I have another patient who's a young woman, very active, married, she's 30 years old, etc., who developed the same situation. And of course, they all go and get creams, steroid creams, and all these kind of things. Well, she got well in 4 months.
Right.
But she was a gal that went to the gym regularly, chose carefully what she eats, etc. So those things as we all know, play a role in our health, general health status.
So you gave us a couple of clinical pearls that I really want to touch upon and dig some more out of you. One of them was that people that have chronic sinus infections have a strong association with mold-related illnesses. And then people that have mast cell activation syndrome seem to have some mold mycotoxin IgE reactions. Of course, autoimmune disease patients have mold-related issues. Are there any other major groups? I mean, of course there are, but what are some other major groups you can remind us of that are associated with mold-related illness?
Yes. For example, I mentioned the brain. The brain is the first place that mycotoxins attack. So this is why patients have fatigue, short-term memory loss, sleep disturbance, unusual headaches, have to read the same paragraph 2 or 3 times to understand it, neurocognitive issues, which I read this book. It's back here. It's called Why Isn't My Brain Working?
Yeah, I've read that book.
And so, and because they cause an autoimmune reaction, it's very common to see in these patients abnormal thyroid function. So they're put on thyroid medication and it still doesn't control their symptoms. And you test them for an autoimmune thyroiditis, they're positive. these mycotoxins also change the relationship between progesterone and estrogen in women and lower testosterone in men. This, therefore, causes infertility in couples. I can tell you I have many, many children out there that are called Andrew because the parents came to see me and then they were finally able to have a child. So
okay, so infertility is another major cognitive decline, neurocognitive decline, infertility, for sure. Hashimoto's, autoimmune diseases, chronic nasal issues, mast cell activation syndrome.
yeah, I mean, Addison's disease.
Mm.
It took a while to get the patient weaned off the steroids. And then when he did, we did the testing, started treating him. He doesn't have it anymore.
Right.
So
What's
all kinds of autoimmunity. We did a Jacob Kreutzfeldt patient, and you know how severe that can be to the brain,
yeah,
and got that person reversed.
really interesting. So would you say it's a mycotoxin antibody screen should be thought of as something with all chronic illnesses, for sure, neurocognitive disorders, chronic sinus issues, autoimmune diseases? Because, sometimes the patient doesn't know that they've been exposed to multiple mycotoxin exposures. Sometimes they do. So obviously, if they do, and there's an association with, hey, I lived in this home and I got sick and I saw mold there, then the timeline's pretty clear. But for a lot of people, it's not clear. So sometimes adding different protocols and labs is up there, but cost adds up quickly when you start doing that with people. So what is it, a high priority for you, low priority for you? I mean, you may be a little biased since it's your research, but.
Well, for example, I saw a young mother, 30 years old with 3 little girls.
Yeah.
And she had SIBO. She showed me the pictures. She took in a mirror sideways. She looked 6 months pregnant.
Yeah.
Okay, so we did the test for mycotoxins. It turned out positive. She started taking itraconazole. And because she lived far away, 3 months later, she sends me another picture of her standing sideways to the mirror, and her stomach is flat.
Nice.
So, and I put this in many, many, many of my PowerPoint presentations that I give. So, because a picture tells a lot more than words. The other thing is, I see commonly patients who have been treated for Lyme disease 3 years, 5 years, one woman, 7 years. They're still sick.
Right.
So do a mycotoxin test, because there's cross reactivity between Lyme testing and mycotoxin testing. So they're tested. And then the other part is many of the tests for Lyme's are IFA, immunofluorescent assay. We've all walked by the ocean at night and see fluorescent things in the water. You walk by the same spot and there's nothing fluorescent. Well, that's because light affects it. But these fluorescent tests are done under a light microscope. They're read by a technician under a light microscope, so there's variations.
Right.
The other part is the best test for Lyme is an antibody test. And it's the only test that is for Lyme that is patented is a test at Immunosciences, and it costs less than these other tests.
Right.
The IFA method is 68% precise. That means 1 out of every 3 is a false positive, false negative. The one done on antibodies is 96.6% accurate.
So what you mean? So there's a percentage of people that get tested for Lyme disease, may have suspicious positive results, or be diagnosed as Lyme disease. But some of those may just be cross-reactive markers that are showing up because they're cross-reacting with my mycotoxins. Okay.
So why would a patient still be on antibiotics 3 years later, which has completely destroyed their microbiome? And we know that 80% of the immune system is in the gut. And they still continue with the same, just using different antibiotics. It doesn't make sense, because if you continue a treatment, you're not getting better. Maybe it's a different diagnosis.
Right. So let's talk about the scenario where you do the workup, you evaluate them, you find that they have mycotoxin antibodies. Mold's a key trigger for the immune system. Now, obviously you want to remove the source. So I want to remove the source. I want to talk about that. I wanted to also go into the second part, which is what antifungal medications you found been very beneficial. And then number three, supplements. So if you can touch upon those, that would be fantastic. So you have a patient, mycotoxin positive. Now what?
Next thing is get the patient away from the toxin, or the toxin away from the patient, which is the most difficult part. I mean, now they've got to find somebody to come and remediate the mold. Now, 50%, and this is in publications and included on the EPA website, 50% of mold in an indoor environment cannot be seen, meaning it can't be seen by the eye. Why? Because it's in between walls. It's in air conditioning ducts. It's in the attic. It's in a basement, etc. So you can't see it. So, but mold guy comes and they remediate the house. Once the house has been remediated, and you tell the people during remediation, go visit a relative or go visit someone that you haven't seen in a long time, but don't be in the home, because that's going to stir up all the spores. And then you start treatment. What is the treatment? Itraconazole, 100 milligrams, twice a day, and you take it with a little bit of food so it absorbs better. You take a bite of an apple, bite of a banana, and it absorbs better. It doesn't matter whether you take it with or without breakfast or dinner, as long as it's twice a day. And it's 100 milligrams. And if a person starts having issues with the itraconazole, it's usually, that's when I tell them switch to Sporanox name brand, like nausea or heartburn, et cetera. I say, okay, let's switch you to Sporanox. And sure enough, those symptoms go away. In the beginning, I used to test them for liver function tests every 3 weeks. And then nothing happened, so I did it every 6 weeks. I still never had a patient with elevated liver enzymes. So I pushed it out to 6 weeks, just so that insurance companies would not start saying whatever they want to say. So I check their liver enzymes every 6 weeks to 2 months, just to be safe. In over 14,000 patients, I have yet to have a problem. The other thing is, I want to give them things like phosphatidylserine for their brain. I want them to make sure that they take omegas, anti-inflammatories, curcumin, turmeric. I want them to take resveratrol. You have to be careful with glutathione, because there's one mycotoxin, it's called gliotoxin, it really affects the brain, that with glutathione, it actually causes the mycotoxin to increase in toxicity. If they have that, then don't give them glutathione. If they don't have that one, glutathione. And there's various preparations of glutathione that patients can conveniently take.
Right.
I like the best one comes in a blue bottle by Apex.
I agree.
But it's really good. Because I look at what patients tell me.
Yeah.
And they love it, because they said within several days, and sometimes they say within 5 days, I noticed it. I'm sure it's subjective, but if it works, I want that for all my patients. Mm-hmm. So glutathione, and then you want to also give them magnesium. I published an article on magnesium years ago, and your regular magnesiums that you buy, you pee out within 4 hours. It peaks in 2 hours and you urinate it out. So I use Mag SRT, which is a long-acting magnesium, but whatever the patient or the clinician wants to give them, that's fine. And lastly, I want to make sure that they take melatonin. About 3 milligrams is all they need. Studies from University of Texas in San Antonio with Dr. Claudia Miller and others have shown that that is a neuroprotective vitamin, if you wish. It's not really a vitamin, it's melatonin. Yes, it'll make people sleep or sleep better, but really it's for a protective element of the brain. I want to make sure the patient is on vitamin C. And I don't give small amounts. I give like 1,000 milligrams throughout the day. 6,000 a day is minimal. And we've all read, or some of us have read Linus Pauling's studies. He's the only guy that's one of the few people who won the Nobel Prize twice. He did a lot of work on vitamin C. There is no toxicity in vitamin C. You can give 1,000,000 milligrams. It can't harm you. Can you believe that? Anyway, but it can cause gut issues if you get too high. So you want to get that down too. Get that on board, the patient. The other things that I like to do is if they've got a lot of brain issues, I like to use nitric oxide. This dilates your blood vessels and gets more nutrients and oxygen to the brain. And got to treat the gut. I use spore-forming bacilli to treat the gut. Dr. Paul, not Linus Pauling, what's his name? Simon is his first name. Cutting. Dr. Simon Cutting at Reading University in London did studies on the gut, on the stomach, and on probiotics, and he found that a lot of probiotics die in the stomach due to the acidity, over 90% because of acidity. So it's best to use something that gets through that acidity, and that's spore-forming bacilli. And really, that's it. Now, there's and that helps all these patients that are SIBO and are being treated with antibiotics. It's the mycotoxins that have changed the microbiome, because many mycotoxins cause leaky gut, intestinal permeability. So when you treat the cause of the intestinal permeability, guess what happens? The zonulin closes up. I've discussed this with somebody you probably know, and Alessio Fasano, where I went to school in Switzerland, was 2 hours from where he went to school in Italy.
Nice.
By train. So but he talks about, as you well know, zonulin and all the various issues. And he has said, yes, and I've shown him some of the studies and photographs with before and after test results of mycotoxins, antibodies. And he says, yes, that was it.
Interesting. So what do you think where's the role come in with nutraceuticals that are antifungals, like caprylic acid, olive extract, oregano extract? Do you think they have some use? Do you think they could be used in lieu of antifungal medication, or they're just not going to be strong enough? Or a combination approach? What do you think?
Some patients have come to me and they've tried all, like oregano oil and biocidin and various other things. And they've tried it for a while, not just for a few months. They've been on it like a year, 2 years, 3 years.
Yeah.
Still sick.
Yeah.
It takes me at the most 8 months to get somebody well. A lot of these patients have been on binders. Well, binders, the studies on binders have been done on all kinds of animals: sheep, goats, cows, chickens, and piglets and whatnot. There isn't a single study that has been done binders in humans. I have to go by medical evidence.
Right.
Not I saw a patient that got better. No, because I get 5 emails minimum daily, 7 days a week, from patients who've been on binders for 2, 3, 4, or 5 years that say, I've been doing this. It hasn't helped. What should I do?
Okay. What about things that break down the biofilm and biofilm disruptors? Do you think those are important to do, especially with sinus-related issues, or what are your thoughts?
Only if they have very tenacious sinus issues and they're not getting at it. After 3 months, they're still feeling real bad, then yes.
Okay.
And then only in sinus issues.
And for people that, let's say their source has been removed, maybe that home remediation, or maybe they just moved altogether, and they go into a protocol like you suggested here, in your clinical experience, what time frame do you start to see things change?
I see most patients, and this is, it's the bell curve. So the majority within 8 to 12 weeks really start feeling difference. I spoke to a person last night. He's 61 years old, and it was his 55th day of treatment. And he says the difference is remarkable. So that's tells you, for him, it's 55 days.
Right.
A couple of months, it's less than 2 months. And he was just thrilled. He had to talk to me.
Okay. So to kind of recap and get some last piece of advice from you, I mean, just as a recap, we know that mold illness is a real serious issue. We definitely want to suspect with autoimmune disease, things like neurocognitive decline. There could even be IgE mycotoxin responses to people that have mast cell syndrome. People that have chronic sinusitis issues for sure need to be checked. Anyone that feels sicker in their home, they leave and they feel better. Those are obviously red flags. Interesting to learn about breast implants that may have mycotoxins in them from the manufacturing process causing chronic illness and so forth. And then you can use the mycotoxin test before and after to determine if the toxic load is being removed and if it's effective in the protocol. And then you can go into treatment, removal, antifungal medication, nutraceuticals, improve the immune system, improve the gut barrier, improve the microbiome, give them antioxidants, and then go through that process. Any other key pearls you want to share with us you think we should know as clinicians working with patients that are chronically sick and dealing with mold-related illnesses?
I think it's, in a lot of cases, it's a sense of experience.
Mm-hmm.
The first 10 will be the most challenging. The next 20 will be less challenging. And after you reach a certain level, you're very comfortable. You know what's good for a patient that's 22-year-old and weighs 110 pounds, and somebody who's 55 weighs 220 and has hypertension and is a male, and you'll be able to juggle these differences, which is why protocols in and of themselves don't work, because protocol treats everything the same.
Right.
So, you use your clinical knowledge of that particular patient.
Right.
Individual. Yeah. And you use that. I remain open. My email is immunedoctor@gmail.com. And I speak to doctors in Iceland.
Great.
New Zealand, India, St. Petersburg, Russia.
Right.
Cambodia.
Right.
Who do the mycotoxin testing for their patients.
Right. So one last thing I want to ask you about is the whole litigation legal world always comes to light if you're working with a lot of mold patients. Patients get sick and they get angry, and whether it was their home environment where the builders didn't do the proper setup, or if they purchased a home and there wasn't disclosure about mold, or maybe it was breast implant issues. I'm sure you've been dragged into expert opinion for mold cases and other types of things. What do you do when those situations come up? When the patient's like, "Hey, I'm so angry and I want to do, I want to do litigation," and how do you get dragged into those things? And other practitioners sometimes to deal with this. What's your opinion, advice, suggestions regarding that issue?
Yeah, I just say I'm a medical doctor. I don't get involved in the law. Mm-hmm. That's up to the relationship between you and your lawyer. Just like I'm not going to mix in that relationship. I don't want him to mix in our relationship.
Right. But sometimes you may get asked, "Hey, can you write a letter? Can you give a personal opinion of, I think mold is making me sick?" How do you handle those situations?
What I do is, again, you stick with the medical science and you say, this patient, you do it like talking. If I were to have a patient and I would be discussing it with you, right. This is a 32-year-old female who showed up with these symptoms. Examination showed such and such.
Right.
Previous medical records showed this and this. I recommended she do such and such tests. These tests showed this and this, and she was treated for those.
Okay, it's just like a very plain and black and white narrative no linear conclusion to any one specific thing, right? Which you really can't do. Yeah, yeah.
That's what we do actually for a living in our minds.
Right.
You know.
So I always end these interviews with asking our experts, what advice would you give to new functional medicine practitioners? What advice would you give to experienced practitioners?
I would say, don't use protocols. There's now this new visual test. Well, how do you know that actually works? Is there any studies that you can watch something on the screen of your computer and be tested for? No, somebody's lining their pocket. There's no evidence that does anything. So start looking at evidence. Don't look at opinion. There's a lot of great websites out there that hawk all kinds of things, but stick with what medicine and science says for your patients. Don't do whatever weird stuff out there.
Right. And for advanced, would it be the same thing, or people that are very advanced? Would we give the same advice for advanced? Is that for both groups?
Everything, yeah. I mean,
yeah.
I talk to practitioners who are licensed acupuncturists.
Yeah.
I have a good friend who's a naturopath in California. I actually published a study with him and his dad, a double-blind, placebo-controlled, randomized study, by the way. I've doctors, ODs, doctors of osteopathy, dietitians and nutritionists. I talk to all of them because it's an opportunity to teach. I've got 100 articles, chapters in medical textbooks, etc. So teach.
So Dr. Campbell, where can people find more information about your work?
Well, you can go to pubmed.gov and type in Campbell AW. Don't type in A because you've 1,600 studies, but if you put AW, which is my middle name, it reduces the scope. Or you can just write to me, email me at immunedoctor@gmail.com, and and that way you don't have to pay $35 to PubMed for the copies of the studies. I'll send them to you for nothing.
Oh, that's very generous. Well, thank you so much for your time. I think you really gave us a lot of information. Thank you.
Good to see you again, Datis.
Thank you so much.